Good day, I am Clinical Clerk Dave Marquez, and today I am going to demonstrate how to perform an endotracheal intubation.
For our case scenario, a 25-year-old male policeman sustained multiple gunshot wounds at the abdominal area while apprehending a riot incident. The patient was brought to the ER for resuscitation and stat intubation. The patient has the following vital signs: a BP of 70/40 mmHg, a heart rate of 130 bpm, respiratory rate of 30 cpm, temperature of 36 degrees Celsius, and an O2 sat of 90%. As a physician on duty and an expert in intubation, formulate your plan on how to do the intubation process. The patient is currently GCS 8 and will be scheduled for an emergency exploratory laparotomy after stabilizing and resuscitating the patient. So this is a case of a penetrating injury to the abdomen. Our patient is hypotensive, tachycardic, tachypneic, and with a decreased O2 saturation. The Glasgow Coma Scale is only 8, which is already an indication for endotracheal intubation. Now here are the factors specific for my patient that warrants a rapid sequence intubation. Now we are anticipating a deteriorating course of the patient that will eventually lead to respiratory failure. The patient is hemodynamically unstable, has an increased respiratory rate and a decreased O2 saturation, and a GCS score of 8. But prior to intubation, all the materials must be prepared and all the equipment must be ready. Just a rundown, we use the mnemonics MAINS. The M stands for the monitors. It includes the cardiac monitor and the pulse oximeter. All patients undergoing endotracheal intubation should be placed on a continuous monitoring equipment, including the heart rate, respiratory rate, blood pressure, and the continuous oxygen saturation monitoring. Capnography should be employed when available. Next, A stands for airway. It includes the laryngoscope, stethoscope, endotracheal tube, the stylet, the syringe, and the ambu-bag. Since our patient is a male, the ideal size for the endotracheal tube is 7.5 or 8 millimeters in diameter. A 10 ml syringe should also be attached to the tube. And also, check if the laryngoscope is working or lighting. Next, I stands for the IV fluids. Now, we must establish IV access to ensure adequate hydration and avoid hypovolemia and further hypotension since our patient is already hypotensive. It is also used for establishing the route for administration of the drugs. Then D stands for the drugs. In our case, we will use etomidate for the IV induction agent since our patient is hypotensive and hemodynamically unstable. We will give 0.2 to 0.4 milligrams per kilograms of etomidate IV as a sedative. And for the neuromuscular blockade drug, we will give rocuronium 0.45 to 1.2 milligrams per kilograms IV due to the lesser side effects compared with succinylcholine and the need for a prolonged intubation prior to surgery, since our patient is also scheduled for emergency exploratory laparotomy. Also prepare Sugamadex as its reversal agent. And lastly, we have S, which stands for suction and suction catheters to remove other secretions. Another mnemonic which will help us remember all the instruments that must be present in our intubation tray is the SALT PS. This includes S for suction, A for airway, L for the laryngoscope, T for the endotracheal tube, P for plaster, and S for the stethoscope to confirm the placement of the ETT.
And also prior to intubation, we must assess the patient's airway for possible difficult intubation using the mnemonic LEMON. L stands for look externally, E stands for evaluate the 3:3:2 rule, M for the Malampati score, O for the assessment of any obstruction, and N is for the assessment of the neck mobility.
Look externally and inspect for signs of trauma on the face and neck and other abnormal anatomical structures that can make the intubation difficult. For the 3-3-2 rule, the distance between the upper and lower incisors should measure at least 3 finger breadths, which indicates adequate mouth opening. Hence, we will be able to access a sufficient glottic view. Another 3 finger breaths for the distance between the hyoid bone and the lower border of the mentum, which means that the patient's mandible is large enough to accommodate a normal-sized tongue. Hence, we have the ability to deflect the tongue with the laryngoscope. And lastly, 2 finger breaths for the distance below the floor of the mouth or the hyoid towards the thyroid cartilage, indicating an adequate neck length and allows us to predict the location of the larynx from the base of the tongue. Also assess the Malampati score. Higher scores indicate poor visibility, hence the more difficult the patient is to intubate. Then check for any obstruction of the upper airway by listening to any stridor or muffled voice. Any obstruction may restrict visualization of the vocal cords. Then assess for limitations of the neck mobility. Normal flexion is about 30 to 35 degrees. However, in emergency cases, such as in our patient's case, an immediate resuscitation and intubation is crucial. Hence, we may not dwell too much on this kind of assessment. Now, the ideal positioning for direct laryngoscopy is achieved by putting an 8 to 10 cm occipital rest in the form of towels or pillows that provides a sniffing position and an approximately 35-degree neck flexion with cervico-occipital extension to achieve a straight line of sight from the mouth to the larynx and prevent a right angle obstructing the view and the line of intubation. In this demonstration, we lack a table with a proper height due to limited resources, but ideally, to avoid bending over, elevate the table to the level between your xiphoid process and the umbilicus, which is also the level of the head of the patient. Now, suction any pulled secretions. Then, a jaw thrust maneuver can elevate the occlusion in the upper airway in unconscious patients and re-establish airway patency and flow. This is done by lifting the mandible forward and preventing the tongue from obstructing the trachea. Then, insert an oropharyngeal airway to temporarily facilitate adequate ventilation. Pre-oxygenation using the bag valve mask for 3 to 5 minutes effectively leads to nitrogen washout and prevents oxygen desaturation during the procedure. Make sure that the mask is well fitted and there is no air leak. The superior angle of the mask is fitted into the lowest point of the bridge of the nose. The left hand then lifts the mandible anteriorly until the chin meets the cushion. The thumb and index finger should make a letter C shape around the mask, holding it above and below the connector respectively, while exerting downward pressure, while other fingers make a letter E on the jaw with the 5th digit on the mandibular angle to provide upward displacement or lift of the mandible. Prepare a laryngeal mask airway as backup in case the intubation fails. Then we can now give the drugs. Administer etomidate 0.3 mg per kilogram IV push to produce loss of consciousness. Then administer the neuromuscular blocker rocuronium at 1 mg per kilogram IV. Now to start the intubation, open the mouth with a scissors technique. The scissored thumb and index finger of the gloved right hand touches the right mandibular and maxillary premolars to open the mouth. Prior to intubation, you can also perform the Salix maneuver by applying pressure on the cricoid cartilage to occlude the esophagus. Now to begin the intubation, hold the laryngoscope using the left hand with the 5th finger close to the hinge and the handle pointing right to the sagittal plane. Introduce the blade at the right corner of the mouth and sweep the tongue to the left. Now advance the blade until the right tonsillar fossa is identified. Locate the epiglottis medial to the tonsillar fossa and advance the blade further to the midline glossoepiglottic reflection and placing the tip of the blade behind the vallecula to visualize the glottis opening. This will also allow to distinguish the glottis opening from the esophagus to avoid esophageal intubation. Avoid levering the laryngoscope against the maxillary teeth in order to avoid teeth and gum damage. So just remember to keep your wrist fixed and move the handle of the laryngoscope in an anterior to inferior direction. Now check the patency of the endotracheal tube before intubation by inflating the cuff using the syringe. If there is no leakage, then it's good. So deflate it again and apply the lubricant and insert the lubricated stylet to a point beyond the cuff but not beyond the opening in order to avoid mucosal trauma. Insert the endotracheal tube with stylet from the right using the right hand while holding it in a pencil grip, and make sure it doesn't block the view of the glottis. Advance the tube past the glottis opening until the proximal margin of the cuff is about 3 to 4 centimeters beyond the vocal cords. Inflate the pilot balloon with 10 cc of air. Carefully remove the stylet and connect the tube to the ambubag or breathing circuit. Confirm placement by auscultation of the lungs for equal breath sounds on both right and left upper lung field and the right and left lower lung field, or check the absence of gurgling sounds at the epigastrium. Methods used to confirm correct ATT placement includes clinical assessment by auscultation, capnography if available, and post-intubation chest radiography. Once equal breath sound is achieved, then adjust and secure the tube in place with plaster. You may also insert an oropharyngeal airway to prevent biting and for easier suctioning when needed.
Now we're done with endotracheal intubation. Now monitor the patient during intubation and provide proper follow-up care in order to improve outcome and quality of life.